Good morning, everybody. Okay, we'll be back to this session. This is session 2, and it will be my great pleasure to introduce the speaker for the first presentation, which will be by Dr. Adel Sayad. Dr. Adel Sayad is a consultant family physician. He graduated from Arabian Gulf University, and then he's holding a master's degree in epidemiology. He's currently holding the position as the Chief of Disease Control Section in Public Health and Ministry of Health Bahrain. And welcome, Dr. Adel, for your presentation. Thank you.
Thank you, Dr. Jamila. Good morning, everybody. It's good to start first because people are still here, so I will have some attendees. Our talk today is about measles in Bahrain. And actually, it is about the way for elimination, our strategies and lessons learned, and we'll present some data about the outbreak that we had beginning of this year. The contents of my talk will be about introduction, measles elimination strategy, vaccination strategy, surveillance, measles outbreak, and conclusion. As all of us knows, measles is a highly contagious virus disease. It affects mainly children. Transmission via droplets from the nose, mouth, or throat from infected person. Incubation period, 7 to 18 days, but usually it is around 10 to 12 days after infection. And period of communicability, and this is important, 4 days before the appearance of rash and 4 days after the disappearance of rash. Symptom signs, runny nose, conjunctivitis, colic-like symptoms, maculopapular rash, and of course, I'm missing here the fever. Fever and maculopapular rash is used for surveillance. We'll come to that. So high fever and maculopapular rash is the main 2 symptoms that we depend on for our surveillance system. Measles complication, as all of us knows, blindness, encephalitis, severe diarrhea, ear infection, and pneumonia. Now, I'm going to talk about our strategy in Bahrain, and this is a strategy that is adopted from WHO strategy to try and decrease the burden of measles and to eliminate measles from the country. We have 3 main strategies. We have, I don't know that it is clear, the blue one is talking about vaccination. This is a vaccine-preventable disease, so the mainstay of our strategy is vaccination. The second strategy, the red one, is surveillance, and the third one is second opportunity for measles immunization, including catch-up. And we'll try to highlight how we did that in Bahrain. We'll start with the first strategy, vaccination. And the target here to have a coverage of more than 95% for MCV1. A brief historical background about vaccination in Bahrain. Measles vaccination in Bahrain started in 1974 at 9 months. And until 1985, when we added MMR as a second dose of measles-containing vaccine. So from 74 until 85, we had only 1 measles-containing vaccine. Then in 84, we added MMR as a second dose at 15 months. Then in 1998, we stopped measles-only vaccine, and we shifted the schedule to measles MMR at 12 months and at school entry. And then we did the catch-up vaccination campaigns for children, school children, until from 1998 until 2006. In addition to that, we did a national campaign for the age group of 1 to 7 years. and 2000 MMR was started for postpartum non-immune women. This is the current schedule for children, MCV1 at 12 months and MCV2 at 4 years. And as we mentioned before, this has been changing over years, started 74, changed in 85, changed again in 98. This is the vaccination, but again, we have another strategy. We have a second opportunity for measles immunization, including catch-up campaign for susceptible, and we started that actually when we changed the schedule in 1998. So we did a nationwide MMR campaign in 1998, targeting those between the age of 6 until 18 years of age, and the coverage was excellent, 97. And again, we did a nationwide MMR campaign in 1999 for the age between 1 to 7 years, 90%, and catch-up campaign continued from 1998 until 2006, when all the cohort completed the 12 years old, and the coverage was 95%. Based on that, based on all the activities, the vaccination is excellent in our community. In addition to that, we have MMR measles beyond the childhood vaccination. For susceptible adolescents and adults without documented evidence, we do vaccinate them. Healthcare personnel, it is mandatory, and military workers, it is mandatory for them to take MMR vaccine. Medical college students, international travelers to certain countries, unvaccinated adolescents or adults in household, school, or workplace where measles, rubella, or mumps cases identified. Once we identify a case, all the contacts who did not receive their MMR vaccine will receive their vaccine. So measles vaccination is not only for childhood, it is beyond that. So based on that, all the activities that have been going on since 1974, we can notice a dramatic change in the number of cases of measles from over a decade. In the decade 1970 until 79, we can see that on average we had 2,300 cases per year. On the second decade, after the introduction of measles-only vaccine, we noticed a dramatic decrease, and we had around 712 cases per year in the 1980 until 89. And that's the decade where in the middle of it, we introduced the second dose. The second dose effect appeared in the statistics in the third decade, in 1990 until 1999. And as we can see here, it is around 20 cases per year for that decade. In the fourth decade, starting from 2000 until 2009, we had an average of 6 cases per year. This is actually the effect of vaccination, and not only the vaccination, because we need, as part of our strategy, to be vigilant, watch all the cases, and this is where the surveillance comes into the picture. So in surveillance, we look into cases, and this is for communicable disease surveillance in general, and we are talking about measles. So what we do, we start by case detection from the primary healthcare doctors, accident emergency, pediatrician. They diagnose based on the symptoms, and mainly fever and rash. Then they would report the case to the public health. We will confirm in public health whether this is a measles case or not. We'll have our registry. Of course, we will analyze and interpret the results, and we will do response. If we have a confirmed case of measles, then there are a lot of things to do, mainly taking care of the contacts whom are at risk of getting the disease, and by making sure that they fully receive their vaccination. Then, after doing all the response, we'll have a feedback back to the healthcare worker in the primary care, pediatrician, all the levels. And as most of you know, this is our reporting form on the right side. Measles is from the group A disease, where you should, as a healthcare worker, should report within 24 hours if you suspect a measles case. And the second part of the slide is the algorithm that is available to all healthcare workers. We don't depend only on passive surveillance. For surveillance, we have what we call passive surveillance, where we sit in our office and receive the notification from the healthcare workers, clinicians in their clinics. But we do what we call active surveillance. We go out from our office and visit the hospitals, visit the clinics, see if there are any cases that have been not reported to us. And we do this to all the hospitals, mainly Salmani Medical Hospital and other governmental and non-governmental hospitals. We do calls for the health centers, and after all, also we do review the medical records for admission of any missed cases. So this just to make sure that we don't miss any diagnosed case that have been not reported to us by passive surveillance, so we do also active surveillance. If we have a good surveillance, especially for measles, we will be able to do all of these rules. We'll be able to detect and characterize cases and outbreaks. We'll be able to identify high-risk population. We'll be able to monitor and guide programs performance and planning. We have vaccination program. If it is working, then the outcome will be decrease in the number of cases. And this is what we see by doing proper surveillance. Providing feedback on impact of immunization activities to government and stakeholders, and ultimately and hopefully to verify measles and rubella elimination in the country. Again, back to the same slide. Just to show it is not only vaccination that leads us to this, because we got this number because we have a good surveillance system. And this good surveillance system did not start 2 years, 5 years back. It started since the 70s and earlier. So again, the effect here is not only for vaccination, it is also the other strategies that we implement. As you can see that the data here stopped at 2009. So what about the last 5 years? Actually, in the last 5 years, we do have cases. In 2010, we had 2 cases. I don't know whether the numbers are clear or not, but I'm going to tell you about them. In 2011, we had 10 cases. 12, we had 6 cases. 13, we had 1 case only. While in 2014, we had 46 cases. We are going to talk about the good news, and I will say the good news, because although the numbers are increased in 2014, but still they are a good news for us. As you can see, the elimination of measles means that we don't have indigenous transmission of the cases. And this is what happened since 2010. We knew by classifying the cases that all the cases identified since 2010 are not locally transmitted. It did not transmit in the country. So though we had 2 cases in 2010, 10 in 2011, and even 46 in 2014, but all of them have been classified as imported cases, imported virus. The virus was not, the origin of the virus was not Bahrain. So actually, since the last 5 years, we did not have an endogenous measles virus, despite the fact that we do still have cases. And as you can see here, a combined graph of the vaccination. The bars are for vaccination, and the number of cases. And as you can see, the endogenous number of cases are 0 for the last 5 years. So somebody will ask, so what about the 46 cases that you had in 2014? And this is what happened. In 2014, we had this number of cases, and as you can see, it was distributed all over the country. It was not in one place. The cases, the first case identified in January 2014, actually in 25th of January 2014. And by February, we noticed an increased number in comparison to the previous year. By early March, we recognized that we are dealing with an outbreak, and the containment activities started since March. That's why we managed to see a decrease in the number of cases in April and May, and the outbreak dies out in June. The case in September have no relationship with the outbreak, started from January and ended in June. And this is another graph, outbreak graph. As you can see, the orange color is for cases below 1 year of age. Cases that have been not receiving, they are not eligible to receive the vaccine actually. So most of our cases actually are below the age of vaccination. This is an overview about the cases. Just to tell you, we had Bahrainis and non-Bahrainis, but as you can see, 19 of the 46 are infants below 1 year of age. Majority of them did not receive vaccination, those who are eligible to receive the vaccination. Measles outbreak, we had actually 3 clusters. At that time, we identified that the index case was a case coming from India, and she lived in Muharraq, and she spread the disease to her family, and one of her family, this is the first cluster, one of her relatives is also visiting another family members in Manama, where the second cluster have been identified. The serious cluster, or the last cluster, was identified in a pediatric ward, infant ward, where most of the below 1 year old cases have been identified. Response and containment action, just to tell you this is what happened there, and we started certain containment activities. And by starting, I mean it was a group work. It was not only Ministry of Health, it was not only Public Health, it was a lot of departments in Ministry of Health, and a lot of people and departments and institutes outside Ministry of Health. Measles outbreak in Bahrain, we define it by 1 case. So actually, if we have 1 case, then this is an outbreak by definition for measles. What we do, it is mandatory reporting, epidemiological investigation will be done for all the cases, and all the contacts will be evaluated for whether they had the vaccination, completed their vaccination. If they did not complete their vaccination, they will receive vaccines. For this particular outbreak, we had a lot of activities. Vaccination response to identified cases, family contacts, susceptible children below 18 years of age, in the residency area. And this we did, and we expanded the area for this particular outbreak. Usually we do for the block only, one block. In this particular outbreak, we decided it is an opportunity for us, though it was an outbreak and the people were anxious about it, but we thought that this is an opportunity for us to go and vaccinate those who have high risk of getting the disease in certain areas. So what we did, we expanded the target of vaccination to include those below 18 years in that area, and we added all the blocks. It is not only one block, we added all the blocks in that area, in Muharraq area, and even the schools in that area. We reviewed all the vaccination status of the students there, and we make sure that all of them are received their vaccination. Those who did not receive their vaccination, we arrange for them to take it. Of course, the third cluster actually was related to Salmania Medical Complex. And we take this opportunity to strengthen the infection control procedure and to try and educate the healthcare worker about the importance of infection control in their setting by showing them if they don't follow that, what will happen. Actually, it was again an opportunity for us to emphasize the importance of infection control procedure in secondary care setting. Of course, what we did also something different this time with this outbreak is what we call social mobilization, because we approach the community leaders. In our case, the second cluster was in Manama, and it was related to a service in the church. So we approached the priest in the church, and we arranged with them for their followers in the weekly service to receive the vaccine there in the church. And they were very helpful. Moreover, we did this with community leaders in Muharraq, religious and community leaders, and we arranged with them to increase the awareness of the community there, so they were involved in and helping us in doing that in the community. The way forward. Based on what we experienced over years, and especially last years, we identify that we are still at risk of having the disease. Though for the last 4 years, 5 years, we are okay. We don't have any endogenous cases, but still we are at risk. And actually this applies to all GCC countries because of high number of expatriates with unknown vaccination status. The other thing that we learn here, that it is always good to do the social mobilization and involve all the concerned parties in your outbreak containment activities. And this is what happened, and this was what make us succeed in controlling this outbreak. So, what we are aiming to is to continue surveillance in order to achieve and maintain 0 cases, continue immunization monitoring in order to sustain high immunity profile in the community, and study different strategies to determine the best for management of non-immune expatriates. And of course, we are looking forward to be the first country in the region, in the Middle East, to be validated as achieving measles elimination. And thank you.